Okay, why don't we get started? It's 10:02 or 1:02 or 12:02, wherever you are. So welcome everybody. We are so happy to have this panel today, and we have a great session planned. I'm going to quickly. I'm Shraddha Mittal. I'm the co-founder here at HiBoop. I'll quickly go over the agenda so everyone knows what to expect. We are going to have the panel discussion first, which is why everyone's here, to hear from our great panelists. And we're then going to follow that with the HiBoop demo, which is going to be given by Kate, which a lot of you know, who's our director of sales. Next, we're going to give you a sneak peek into our roadmap and upcoming features, which is going to be done by Madeline, who's our director of customer client success and customer success. And then we're going to have a 10-minute open discussion for all of you to talk to clinicians, physicians, to talk to each other, and we'll bring up all the questions that come up during the panel. So to start, though, I thought that we could have Jason introduce himself. And Jason, as I'm going to ask him a question as the founder of HiBoop, and you've been in the center of this journey. Start by telling everyone a little bit about yourself and why did you start HiBoop?
Yeah, we've only got an hour, so so HiBoop. So disclaimer, like I'm not a doctor. I know a lot about mental health because I was on the outside looking in, trying to figure out answers. And after I sold my last company, which has nothing to do with this space, and finally got some results, like some sort of lens onto what has been going on for 40 odd years. I think it took a lot of effort, a lot of self-advocacy, a lot of, showing up at the walk-in clinic with like somatic anxiety and so I spent a lot of effort and time to get to a pretty, basic, comprehensive look. And for me, I was just kind of like, that is a really long wait time. Like, we complain about sitting at that hospital for 6 hours. 40 years is a pretty long time. And I was like, there has to be a better way. It's not for lack of caring. You guys are all, amazing professionals. It's just it's starting point. And if we just start on a singular approach, I like to think more comprehensive measurement-based care. So we'll get into the product stuff, and I don't want to use up too much time. But the idea was to create something that's more accessible to the people that are, in care of these wonderful humans that are trying to figure it out, and to use all the science that's out there. We know it's imperfect, but so are we. To build something that expedites that comprehensive starting point, and then tracks it. How is this working? How does it work with this cohort? This, psychotherapy, or this cognitive therapy, or this pharmaceutical. How are we doing? I don't have to explain measurement-based care to anybody here, but it was the idea of this moving away from a transactional approach to a long-term approach. So here's the starting point. There might be other, starting points, but let's track this over time and allow that individual, when they move from, let's say, a primary care center to, a secondary counselor or doctor, that information is not lost. And the work that person, both people, the provider and the individual, have done, doesn't just recycle and reset. So hopefully that's less confusing than I just confused myself. But we'll get into it. You'll figure it out all by the end. So and on that, I just wanted to welcome, obviously, our three panelists. It's somebody's just joined. It's a pleasure. Everybody here we've spoken to at some point or another, so this is a kind of intimate group of people that we deeply respect and would love your feedback as we kind of roll through. So I will I'll save a minute, and we can move on. Try to.
Awesome. Thanks, Jason. And I mean, it's a great setup for our discussion. So I'm thrilled to be joined by Yelena. And I echo everything that Jason said. Like, there's so much respect here and love and care for everyone on this call. So excited to be joined by Yelena, Chorny, Stacey, and Jill. Thank you so much for doing this for us and for the mental health space, for all you do. So to get us started, I'd love for each one of you to briefly introduce yourself, and maybe as a opening question, like, what is the biggest myth about measurement-based care that you'd like to bust today? So maybe Stacey, we could start with you.
Hope everybody can hear me okay. Good morning, everyone. It's my pleasure to be here this morning representing the Canadian Addiction Treatment Centres. So I'm Stacey, I'm the Vice President of Clinical Operations. CATC, for those of you that don't know, we're one of the largest providers of mental health and addiction treatment, and we span the full continuum from outpatient to inpatient, harm reduction to abstinence, to then virtual counselling services. So I guess for me today, one of the biggest myths when it comes to measurement-based care is, I think from the clinician standpoint, there's so much maybe fear and anxiety around how much time is this going to take? I'm already busy carrying my caseload and working with clients. So I think that's probably one of the myths I would point.
Thanks. Jill, do you want to go next?
I think, so hi, I'm Jill. I'm the founder of InFocus. It's a neurodiverse virtual clinic working with psychiatry down for folks looking for assessments for ADHD and autism, as well as specialized like clinical services, counseling, coaching, those kind of things. And I think the biggest myth with using like measurement-based things is that it's not decolonized and it's not human-centric. And I think that's, from our lens, something that we work really hard at debunking, but is a really big myth within the measurement-based systems.
Thanks. Yelena.
Hi, everyone. I'm Yelena Chorny. I'm a physician, former chief at Homewood Health Center, former chief of addictions at Homewood Health Center, where I did a lot of measurement-based care. I think one of the biggest myths that people have is that measurement-based care, particularly in mental health, restricts kind of creativity or flexibility in treatment processes and treatment pathways. That if we're focusing too much on particular measures of outcomes, that might kind of divert people's ability to make the treatment decisions that they think are best based on their clinical judgment. And to that, I would say that measurement-based care really offers the opportunity to start a conversation, with your patients or clients about what you're seeing in the measurements. Not necessarily that it prescribes or defines exactly what you have to do with those measurements.
Yeah, thanks. Yelena, while I have you, you've led a large-scale addiction and trauma programs while you were at Homewood. And so from your perspective, how can measurement-based care help scale evidence-based practices across complex systems of care?
Yeah, thanks, Strata. I think first it's helpful to think about the fact that the words measurement-based care probably mean different things to different people. And I like to think about it in three buckets. Kind of classically, when you talk about measurement-based care, it means actual direct, enhancement or support for for, face-to-face or virtual, kind of one-to-one patient care decisions. But it also is used to support quality improvement and, program or clinician evaluation, and it's also used for research purposes. And all of these are really valid uses. When we talk about kind of scaling evidence-based practices, how does it help with that? So measurement-based care is itself an evidence-based practice. And I think that's one of the really fascinating things about it, is that even if we do nothing else, other than screen people using, measures, and then follow up with people and kind of retest over time, and then have discussions with people, even if we don't intentionally put any kind of treatment pathways around that. Just the act of having those conversations and having our patients or clients talk about and think about those results and what they mean, and have us think about that, actually changes and improves people's care. So that, that I think is really nice and a helpful way to think about it. But when it comes to kind of program quality improvement or research, then obviously it also helps people to identify at a broader level, patterns of where certain populations are being helped, where there might be gaps, and then to actually, change and evolve programs and services to meet those gaps.
Yeah, I like how you kind of connect all of those. And Jill, just to kind of carry on that conversation, could you share with us how measurement-based care is changing the way clinicians think about diagnoses and treatment planning? Because I feel like, again, there are hurdles to it, so it would be really great to hear that from you.
I think the measurement-based care model opens a door, or like a lens into kind of what potentially is going on, not just the presenting piece that we see when a client walks in, but kind of some of the underbelly that's happening for them as well, which allows a clinician or a physician to jump off of that, to have conversations to either confirm it or say that's not a piece right now, but it opens that conversation lens. And if we look at a lot of racialized folks, if we look at the notion of language barriers and all of those pieces, sometimes what the matrix or what they're expressing isn't necessarily what's happening based on stigma, based on being pushed out of a system. And this allows to have stronger conversations in a very carefully languaged way, to be client-centered, to honor their humanhood, but also honor their experiences that are more than a number, but then the matrix allows for that door to open to have that conversation. And so our clinicians are able to better tailor their care plans, better able to tailor the way that they're approaching clients. And also when we look at risk and safety, being able to keep those pieces in the back of their mind so that clinician or that doctor is also supported in terms of safety and wraparound care for that person, without as many surprises. There's always going to be surprises, but they're not going to be as sharp and quick with those pieces of the puzzle all going well.
Yeah, I mean, I also hear about I think also data is so powerful, right? I mean, when for your patients, I have a question about data, but I'm going to hold off on it. But you talked about something that I want to ask Stacey a question on. Stacey, you work with your teams on the ground, and so what are the biggest hurdles the clinics and your centers or the clinicians at the centers face when they're trying to adopt measurement-based care?
Yeah. So I think probably one of the biggest hurdles for so I don't work in the clinics, but in the centers, I would say the biggest hurdle for the clinicians is really around workflow integration. So clinicians, they're busy, they're carrying large caseloads. So to administer a number of different psychometric assessments, it just adds another layer to their operational duties. So I would say workflow integration is definitely a challenge. Also, sometimes the lack of the interface between measurement-based care and then the technology. So having a really robust electronic medical record that can interface with the standardized assessments can also be a hurdle. And then the training and kind of that cultural shift. So I was a clinician a long time ago, no longer a clinician, but I remember, the paper and the pencil. So we would administer, multiple paper copies of different assessments. And so having that shift between paper and then leveraging technology, it can be a bit of a challenge for people. It's moving into, the way of working now, which is much more efficient, but it takes time. And so being able to support, supervise, and train people, not only on how to use the technology and how to use the measurement-based care systems, but also just being able to then articulate the outcomes to the client and the why behind moving into that new way of working. So I would say those would be the biggest hurdles for staff.
Yeah, thank you. And I mean, I'm very proud to say that CATC is a customer of ours, and we've rolled out to all three of their centers. So, Stacey, I mean, you've overseen the HiBoop implementation. What outcomes or efficiencies have been most meaningful for your teams in terms of, like I think there are different, it's to the business, to the clinicians, to the, maybe you can kind of even categorize it and tell us how it's been and the value behind it.
Yeah, I think the substantial efficiencies with kind of the clinical outcomes, the operational, and then there's financial efficiencies. So I'm going to kind of break this down. I would say, first of all, the streamlined clinical workflows, right? So we're reducing documentation. We're able to assess clients on admission, midway, and at discharge. So average length of stay for our clients is around 42 days. And so we have a really clear kind of depiction of symptomology and symptom distress, and certainly a focus on addictions on day one. And then that information can help inform treatment planning and treatment goals. We can then track in real time the changes that are occurring from admission to midway of treatment. That continues to help evolve the treatment plan and start to think about aftercare and discharge planning. I think client engagement is another efficiency. I think we work really hard at engaging our clients with that buy-in. And so when they've bought in, it just becomes another part of their treatment. And they're able to see how their change is progressing as a result of the treatment. So an efficiency standpoint in the sense of we get clients buy-in very quickly because they can see the data in real time. The enhanced care coordination that comes with the multidisciplinary team. So the HiBoop system that we've been using has really enhanced our collaboration with psychiatry, with the MDs, the nursing teams, and it helps to just continue to shape that care planning. Another huge efficiency is our relationships with our referents. So they have been asking for measurement-based care. They really value the opportunity to see the reports that we can run. And again, that helps to really demonstrate the level of engagement and the changes that we're making in the patient's journey. I would also say that we track AMAs, which are clients that leave treatment early against medical or program advice. And so again, I think there's a really unique niche with this, that HiBoop has really helped to maintain motivation and engagement for clients. So it'll be, I think going forward, it'll be really good to see how we can leverage data-driven decision-making and really help to shape and prevent some of the AMAs that we sadly see. From a financial impact, there's cost containment with this. Like we're able to identify risks really early, and so being proactive and preventative, we're able to again reduce those AMAs. We're also able to match the client with the right level of care and the right level of intervention. So I could talk a lot about the efficiencies that have come with HiBoop. I've just been just so impressed from day one.
I can put my hand up there, but I just have one question, which is generally just like a follow-up with all three of you, is something that we hit walls with a little bit is measurement-based care, but they're only measuring their specialties. So we've seen this, like, we don't have a trauma program, so we're not going to look at that. We don't deal with bipolar, so we don't look at that. And just even just from a personal thing, is like, you don't have to have the program, but they should know, and you should know that this might be. You could look at eating disorders or addictions, or like if you don't even understand what might be driving somebody that has come back 7 times, how measured are we doing as a group? That's kind of a statement and a question, but anybody can jump in on that one.
Well, I have an example. So we don't formally diagnose ADHD, for example, but we can screen for ADHD. And so the tool allows us to add in other screeners, which can help with our intervention. So again, we're not diagnosing, but if somebody's scored quite high on some of those scales, the clinicians and the counselors are able to have those conversations with clients. And again, we would make recommendations for a formal diagnosis after inpatient treatment, but it helps to have that information at hand so that we can, we could be curious about that with the client, and then we can also help inform our interventions. So perhaps that person needs more one-on-one time versus being in a group. Maybe there's more relaxation therapy and mindfulness that we need to add into the treatment planning, or CBT. So I like that we're able to customize the tools based on the client presentation.
Jill or Yelena, do you want to comment or say anything?
I can go if you'd like.
Sure.
I was directly pointing that to you, Jill, because I know the frustration, well, in general, but of the frustration with like government programs who like, no, we just do with anxiety, depression, like the rest of it, we don't have the resources, but it's like, you're going to be dealing with that for a long time because you're not doing other stuff. Anyway, go ahead, Jill.
Okay. So within certain like health authorities, things like that, they do only like you come in for one thing, it's only one thing, you exit with the one thing. As a human, we're not one thing. And I think HiBoop as a whole allows us to see a whole image of someone and what's going on. And so for myself, being neurodiverse, being autistic specifically, I've heard no more than I've heard yes in my life. No, we can't do this. No, this doesn't work. No. And so part of what HiBoop offers is a yes. Yes, there's this thing going on. Yes, we can find you a referral. And yes, we can give you a warm handshake. That doesn't mean that we have to be able to do the thing. It means that we have the information to do a handoff in a good way to somebody that we can trust, that we've like had conversation about, that client isn't falling through the cracks in a different way. And so often we'll have folks who come in, doctors will give us referrals specifically for ADHD or autism. And there's a lot of other pieces of the puzzle that are happening for those folks. We can support them, but there are elements like we don't do addiction. We support addiction through counseling, but we don't have inpatient support. And if that person's looking for that, then we can warm handshake that off to another component of the health authority or privatized, either or. But without that information, that matrix, those pieces, sometimes that person isn't going to have that conversation. So there is no way for us to say yes. There is no way for a doctor, for a clinic to be able to do that wraparound support. Rather, they leave with just the ADHD diagnosis in our case, or just the autism diagnosis, but there's other co-occurring things happening that actually connect and sometimes actually exacerbate the symptomology of their presenting thing. And so if we can work together with it, we can actually get more efficacy on treatment, but also more client-centered support that honors that person's like humanhood, but also that human's kind of mental health personality profile as a whole. And I think that's kind of a big one that for our clinic specifically, that HiBoop has opened up, is the ability to maintain that yes. And the yes doesn't mean that we do everything. The yes just opens up that thing to be able to hand off or support in different ways, as Stacey kind of elaborated with, like kind of making that care plan very specific to that person's or that tailored, support. Jason, I hope I answered your question.
You did way more than I could articulate, so thank you.
Thanks, Jill. I mean, that kind of made me emotional to being a part of the HiBoop journey, the yes, Yeah, and so, I mean, for everyone on the call, Jill InFocus and is a customer as well and using it. So, Yelena, I mean, we've kind of talked about HiBoop, but you've seen programs succeed and struggle with implementation. What separates the organizations that thrive with measurement-based care from those that don't?
Yeah, thanks. And thanks to the other panelists. I feel like I'm learning a lot from you as well, which is lovely. So I think my main thing in terms of what helps programs, two things that help programs be successful. One would be to involve their frontline clinicians and patients if possible, right from the beginning of the journey. So not, kind of making all the decisions about why, the organization is going to do measurement-based care and how, and sorry, can you all still hear me? Because my screen went blank there for a second. Okay. And not only bringing in kind of the people on the front lines, at the end of the process when you're ready to go with implementation, but actually involving them right from the beginning so that they get to be part of defining what the value is for them, and what the value is for the patients. And that they're also, I think as Stacey mentioned, really ensuring that you develop processes that fit seamlessly into their workloads, because it is a big challenge. And I think a big part of implementation is that. And even then, even if you've been able to get everybody engaged right from day one, I think it's important for organizations to remember that this is an iterative process. So, it's going to roll out in stages. And some of the stages, initially, you've got to get your processes down. How are you collecting the data? Making sure that you're getting that data done when you want it, and you're, getting the numbers that you want, and you have the processes. And then, beyond that, once those processes are in place, then you can kind of expand what you want to do with it. And so, what I've seen be more helpful is to really narrow the focus at the beginning. So we may want to, as Jason and Jilleun talked about, ensure that we're screening for many, many things. That might not be the starting point, right? Sometimes it can be helpful to narrow down, okay, we're going to focus on these couple of screening questionnaires or these couple of, diagnoses and symptom scores or whatever the outcomes are that you're measuring in order to get people comfortable and confident in the process and then expand from there. So, and then my last thing is go where the energy is. You find your champions locally. There will be perhaps in a bigger organization departments that are more excited about this and more ready for this, and departments that will be, let's say, harder to implement in. Or in a smaller organization where maybe you're dealing with individual, physicians or clinicians, and you might have a couple who are really excited and some who are less so. I would start with the people who want to do it, develop and learn the processes there, and then use that energy to expand.
Thanks. I just want to, I think Kathleen, you had your hand raised. You also posted in QA. Why don't we take one of your questions? So Kathleen had a question: how can HiBoop improve initial intake at a mental health clinic? Maybe Jill, do you want to take that?
Just to clarify, the question is like how overall or specifically? Just because it's like there's two different answers.
Maybe answer both ways.
Okay. So overall, I would say it improves efficacy of client-centered care and treatment modalities that are used for that person and their presenting needs. In the overarching piece, how does it make it easier for like individual clinicians for intake? It allows for so back the story up a little bit. Sometimes clients aren't always super comfortable talking to a clinician or talking to a doctor because of the power differential. Sometimes they don't actually have the exact terminology or words to describe what's going on. I know for myself, I use examples of like, I have a tummy feeling. It sounds like a 2-year-old speaking. But if I can't get the emotion or can't get the feeling, it's something that's happening inside of me. That makes no sense to an intake clinician at all, like absolutely none. But if I have a survey or a psychometric test that I can do, it actually allows me to get the words out that I don't have by clicking a button. And that starts having agency and advocacy for that client to be able to express things that they don't necessarily always have the lived or knowledge that they've accumulated through life to describe something. And now they're actually coming to a clinician on a similar playing field of knowledge. I've answered this. This is actually giving you some information. Now a doctor, psychiatrist, clinician can have that conversation, and they're actually matching each other. And they can actually start to describe things. So you've said this in this survey. Can you help me understand a bit more around this? Now we've actually opened the door for like a healthy collaborative conversation versus a top-down conversation. And I think that starts to also make it so that, and in all of that, we understand that doctors, clinicians, there's a certain amount of time to be able to see a doctor based on MSP funding, based on a whole bunch of different things, government funding, nonprofit funding, you name it. But having those psychometric tests pre-done opens up more time to have that conversation, to meet a human where they're at, versus like, yep, your tummy hurts, great, you can go for a referral, when it has nothing to do with my stomach whatsoever. But we only have 15 minutes, so there's the presenting thing. This actually allows to have that conversation in a much more fulsome manner that had nothing to do with my stomach, but rather had everything to do with anxiety that was building up, and I needed a conversation about that, but didn't know how to get it out. And thus, we now have more time for client-centered engagement. I hope I answered that one in both elements.
No, thank you.
Yeah. That's good. I was just going to say, so Kathleen, we're going to, or anybody who has questions, let's go through. Again, we're not here to sell you or fleece you down for, but many of you have been a part of this journey 6 months ago or even a year ago or whatever it is. We'll go through what we've accomplished so far, which could answer some of the questions. And I will pass that over. And then we'll have like hopefully enough time to chat more.
Okay, Kate, you're on.
Hi, everyone. Thanks, Strata. I'm really mindful of time because I think there's some great questions in. So we're going to give you like a little sprinkle of the platform. Kathleen, hopefully it will also answer some of those questions that you had when it comes to, can you use HiBoop to share assessments or scales before they see a clinician? Yes, 100%. And our goal is definitely to allow treatment planning and time to diagnosis to be sped up through the platform. So let me share my screen here. Everybody's going to see themselves for just a quick second because I am going to share the entire thing here. Okay. All right. Can everybody see that okay? Perfect. So, for those who are new to HiBoop, we are a smart mental health assessment platform and supporting measurement-based care through a lot of our reporting and a lot of our data components. We work with clinics and centers of all sizes. We also have a very proprietary algorithm that works with our pre-screen. So our pre-screen is based off of the 23 questions of the DSM level 1, which is that cross-cutting assessment. We also add additional screeners that aren't covered in there to try and get a bigger picture or a better baseline, something like what Jill mentioned, to help right from the get-go. And that way you can either triage that to other referrals, or you can just make the treatment planning a little more specific and catered to that patient. We're going to focus on 3 little areas of the platform. There are a few other settings, and happy to walk anybody through that should they be interested. But today we're going to look at the assessments available in the platform. We have a ton of different assessments. They range from ASD to the recovery capital, substance use disorder, resilience. There is a ton to choose from. So feel free to have a little look as well on our website at those assessments. Next, we're going to look at our patient profiles. So I'm going to move to the left-hand side here, select our patients. And if you are the clinical admin or somebody who does have access to the entire system, this is something that you might see. So we have a few different views up at the top. You can move between new and active, potentially archive patients should somebody have to come back. We also have some alerts here. Alerts can be set up based off of your specific clinic or your center. Right now, this alert is based off of the CIDUS assessment. To add a new patient is really seamless in HiBoop. You can simply click on this left-hand or right-hand menu, add a name. I'm going to go ahead and do that today. So we are going to use, Sammy, and a program to HiBoop allows you to define a standard set of assessment schedules. That could be intake, discharge, follow-up, and they can be used across patients. So one of the reasons that we develop programs is that we know there's a lot of admin time issuing these assessments. So we want you to be able to add your patient to the program. The schedules are already predefined, and those assessments would be automated should you choose to have your patients fill it out via their mobile device or at home. They also can be just scheduled specifically for that clinician who may be having that conversation. So I'm going to use this ADHD program here. I'm going to add an intake date for today. I'm going to just use our little sandbox patient. And then we can assign a care team. So the care team can be a group of individuals. It also could be a very specific psychiatrist or doctor. Perhaps, only that doctor is able to see that patient in those details. So we'll go ahead and assign that today. As we click add and open, we are brought with our new patient profile. And we have the ability to choose how we want to issue the scale. Now, this is our pre-screen. So this is that sort of smart algorithm that would kick in. If we leave the pre-screen on and the patient flags fairly high in severity level of those questions, then it will ask for the additional assessment to be completed to give that larger view or that bigger baseline. We also can require specific assessments. In this case, I'm going to turn that one off today. And then we have a few different ways on how we can issue the assessments, whether that be the clinician mode, so them sitting there and having that conversation and the clinician scoring automatically. We have a mobile device QR code, so your patients can go ahead and scan this. Perhaps they're sitting in the waiting room, or they would, do this elsewhere. We also have the ability to send an email, so the email may look, perhaps something like this. And then we have what we call the same device. We know that, for example, at CATC, they pass their device to another patient. The patient would sit and fill that scale out and then pass it back. And we wanted to make sure that it was really secure when the patient did have the clinician's technology or laptop. So we're going to remember this handy little code here. And I'm going to go ahead and start the assessment. So keep in mind, this is a brand new patient. They are asked to fill out a little bit of medical history or an intake form, and then we would move to the assessments that are required. So go ahead and start the assessment. It's going to say, hi. Our goal is really to make it just as friendly as possible. We know these questions are hard to answer. We know that sometimes the state of mind is not great when you're answering this. So we do want it to be as simple and maybe less noise as possible. We do also give a little bit of information on our privacy policy. We'll go ahead and agree to that and create our profile. And now the patient is going to be asked for a little bit of information. So, we can say this is Sammy, maybe like Sam. We'll add a birth date really quick and pick a day. There is a location. We also ask a little bit of information about their identity, occupation. If they choose not to put any of this in, you do have the ability to go back and edit it when you have those conversations. Let me go ahead here. And perhaps they haven't been clinically diagnosed, so we're going to leave that. Maybe they do take prescription meds for sleep or antidepressants, and perhaps they also had a family member who maybe had previously medical history for bipolar or anxiety. Now we're ready to submit and start our assessment. So at this point, you'll see the 29 questions. That is our pre-screen. As I go through, the platform is going to allow me to answer these as I come to the different questions, but based on the severity level, you will notice the assessment number changes. We don't tell the patients what they're being assessed for. We really do try to eliminate as much exterior, noise so that they can simply answer the questions, and the clinician's able to get, as good of an idea of what that patient might be dealing with. So as we go through here, I'm just going to go really quick so that you can see, this change. But as of right now, I'm answering as severe as I possibly can. And our algorithm would kick in closer to that 29 question. So I'm going to log back out here really quick. And I'm going to show you what a completed patient profile might look like. So we're going to add our little code here. Go ahead and submit. Now keep in mind, this patient profile is not completed because our patient is still filling out that pre-screen, any of the other assessments. So we're going to take a look at John Jones here, and we can see the information that John filled out at the beginning. So that initial intake information. And keep a lookout, Maddie's got some exciting things on this form. We also have our results table. So this is sort of a quick glance on what your patient may be, dealing with when it comes to the severity level that we asked in that pre-screener. And of course, as you continue to issue different skills, you'll be able to see different levels based on those screeners. One thing that we are very excited about is we try to make the UI of the platform really easy to see and understand. So we see the pre-screen. If you'd like to see all of the questions and the scores of the individual questions, you can drop those down. And then we also have the ability to compare these schedules. So one thing that measurement-based care, is looking at is understanding what was the baseline, so what happened at intake, and how did that patient progress across the program that our clinicians are supporting them in. So perhaps we look at intake to discharge, and we can see here that this patient, did have some positive progress, but maybe sleep, or in this case, suicidal ideation, has gone down. So we need to figure out how we best support that patient as soon as possible. The other really great piece on this is what Dr. Jill was talking about when needing to maybe send a referral. So we are thrilled. We actually work directly with her on this to be able to make some of the exports just a lot easier to see and understand. So if we go ahead and export, and hopefully everybody can see this because sometimes the pop-outs are a little bit funny, we have the option to choose the name, email, any sort of details you'd like to share. And when we open up our export view, it looks very, very clean. So you can easily see the entire scale, the full score, and then each individual question and the score. This will help with either your referrals or looking at it potentially in another system or having another psychologist or doctor also look and cross-reference. If we have a quick look now at our reporting section, I'm just going to pop over here. This reporting section allows you to look at the entire assessments across a cohort of patients within a specific date range. You also can compare programs. So we do have some comments that like to make sure that program comparison is accessible. Now, if we take the high-level view of how your patients are doing across the assessments over time, it's going to help track completion. It will also help track view outcomes, and then the change of measure from intake to discharge, as well as the follow-up. Each of these can be dropped down, and we do allow for full exports as well. I'm really mindful of time, so I'm going to pass it back over to Maddie, but if anyone has any questions or if you'd like to trial the account or have a custom demo, we'll be sending out some detail after the panel today.
Amazing. Thank you, Kate. Okay, let me show you what is coming up on the product roadmap. And here we go. Okay. So we really want to show you how we are evolving to make measurement-based care even easier and more impactful in your daily practice. Okay, so get excited. A new experience is loading. So this is your first look at the new and improved HiBoop. So we're reimagining the experience to be faster, smarter, and more intuitive. So let me show you what's on the way. So this is coming up soon. So in the next 3 to 6 months, we are focused on a handful of high impact features. These include refreshed charts and dashboards, AI clinical notes, assessment recommendations, further bolstering our smart form technology, as well as customized intake forms and advancing on that reporting that Kate was just showing us. So each of these has been designed based on direct feedback from clients like yours. So now let's take a little look at each one. Okay, so first, we have refreshed charts and dashboards seen here and here and here and here and here. You'll see a new design, new layout, new colors, built to make data faster to interpret, easier to share, and really just more engaging for both clinicians and leadership teams. Next, we're rolling out a couple of AI-supported features. So that includes AI-generated SOAP notes that you can see here and here. And then enhancing the smart form recommendations seen here and here. There we go. And that will highlight what assessments patients should do next based on our knowledge around mental health conditions overlapping and co-occurring. Don't worry, you'll also be able to add your own custom notes. So our goal with these features is really to reduce administrative time and better support your clinical decisions. Custom intake forms are coming very soon. They are seen here. And this will allow you to tailor the questions that you ask patients before they start an assessment. So some of the requests we've gotten recently include referral tracking or PHN, your personal health number. You'll be able to do that very soon within the system. And we're also upgrading our exports, seen here, so that they're better formatted, easier to interpret when you attach them to your EMRs or share with your referral partners or submit for MSP remittance. And as mentioned, we are enhancing reporting. So we're going to add a new filter, and I kind of zoom in on it right here. So you can go into that report that Kate was just in and filter by patient demographics, by programs, or by care team that's assigned. So this makes it easier to track outcomes across populations, not just individuals. It's kind of like a choose your own adventure style report. And then really quick, because I know about the time, I know we're coming up, but I want to share a high level of what our team is currently exploring. So these areas are in discovery, but I want to give you a sense of where we're headed. So first, we're looking into therapy worksheets, so tools to help patients prepare before sessions and stay engaged between sessions, really supporting that continuity of care. We're looking at child and youth assessments, so expanding our library to better serve children, including parent and teacher assessments, and that allows providers to really capture those multiple perspectives needed for childcare. EMR integrations, yes, we are actively connecting with a few key players in the EMR space to integrate because we know how helpful this would be. These types of relationships, between technology partners can take time, but, our ultimate goal is really to reduce admin and double entry by, syncing that patient data with your electronic medical record so that your workflows are smooth and more connected. And lastly, we are exploring the idea of treatment planning features. So a framework to help track progress, set goals, and tie assessments directly into the patient's care plan. So these ideas are, already being shaped by conversations with many of you, and we'll continue listening as we decide on what direction to take next. So thank you so much for your time and for the feedback many of you have already shared. I'm going to pass it back to Shraddha to go into the Q&A with our amazing panelists.
I would just add on that. So everybody in this group, I'm basically saying the same thing. Whether it's Jill or CACT, and all of you, I did 200 research calls before deciding to launch this. But you're partners. You've helped us create and craft something, and we'll continue that evolution as we go, which is not always like a inherent thing in corporations, but mostly thank you, because what is in there is your feedback as well as our lovely team that goes on it. But all right, Shraddha, back to you.
Yeah. No, I think we all echo how you feel about this, Jason. Kevin, you have a question. I think Shannon from our team is going to let you ask the questions so you can interact with each other. Or maybe I can, oh, there you are. You'll just have to unmute yourself.
Yeah, thank you. Appreciate it. Great presentation this morning, and exciting to see some of the roadmap features that are on the horizon. So in the presentation, the piece that you covered around contextualizing forms and custom forms, can you create a suite of forms that would be served up based on the unique needs of the client? So if we know that someone's registered specifically for support with, the example I gave him, the question was eating disorders or a particular mental health condition, can the assessment be contextualized to specifically ask questions related to predefined disorders or treatment modalities to contextualize that experience?
Maddie, do you?
Sure. Yeah. So I think that's a great question, Kevin. And I'd like to work with you to understand a little bit more of what that looks like in practice. But what we can definitely do today is we can create those programs for the different visit type. So we can create a customized assessment process for the different treatments that you are providing. And then on top of that, we can look at your new custom form that you'll be enabling soon, I'm sure, and filter the report based on what you've entered, what you've created. It sounds like you want to do a little bit more customization in the way the questions are asked and answered. So I'd love to discover that with you. Right now, we do maintain the integrity of every assessment. So we don't change the order, the wording, the structure of any of the standardized assessments that we implement. But with that smart form technology and recommendation, we're always looking at ways to improve. So
Sure.
does that help kind of answer your question in a way?
Yeah, that's helpful.
Okay, well, I'll contact you. I believe you're with, I think I have your contact, so I'll send you a message.
Yeah, and part of it is, thanks, Madeline. We can do more. Like we can go all in and do a lot more, but because we're dealing with, reasonable, security and practice when it comes to what we're doing, the starting point is, kind of here. So we have to conform with that. Otherwise, if it's some, magical, thing, then we start to lose visibility to the small and big credibilities. But
Kathleen, you have a question. Well, let's hear it from you.
Yes, I was just wondering if do any of the clinics use HiBoop as an initial screen, even before the patient's seen by the clinic?
Jill, do you want to answer that?
Yeah, our clinic uses it for all ADHD assessments and autism assessments. So they are given the psychometric surveys before we see them. And then from there, if they're having like challenges filling it out, we will help them fill it out. We will like decode some of what the questions are asking them. Literacy will help them read any of those pieces or use like auditory different devices that will help read for them, either or. And then they will then see a psychiatrist. And the psychiatrist will use that matrix to be able to validate the assessment for ADHD, and then they'll head into a clinical interview for autism, and then a validation from the psychiatrist after both pieces are completed. So yes, 100% we use it before clients are seen by a human. In conjunction, like we'll call them and talk to them to make sure they have all the pieces, but they're definitely seen through psychometric first and then into us.
Can I ask a follow-up question?
So
with autism, do you feel like it's generally underdiagnosed in the population? And do you feel like HiBoop really helps in the diagnosis of it?
Yes, 1,000,000%. I believe it's underdiagnosed. But I also think there's a financial component because it's not funded in the same way. And it's very expensive as an adult to get assessments. So yes, I do think, and there's an 80% overlap between ADHD and autism, and ADHD is a much more financially accessible and doctor accessible test. So yes, I do think autism is underrepresented. And yes, I do believe that the psychometrics support, because when we look at the gold standard of the ADI and the ADOS that also needs to be clinically administered, this gives us the beginning touch points of, is this even something that we should be looking at for this client, so that they're not outlaying like thousands of dollars before we even start the process. This also works with client-centered care. This works on financial literacy. This also supports with being able to meet a client and have a difficult conversation that says, yes, you're presenting with some things, but it's not aligning with this. And we would love to get you into a psychiatrist, but not looking at autism. Let's look at like PTSD, because that's actually what you're presenting with today. And that's not financially, like, yes, we can still do it, but it may not come out with what you're looking for today. So yes, those pre-screeners are so important. That gets us into that gold standard of the ADI and ADOS, and then that clinical interview to then be validated by a psychiatrist.
Does HiBoop overdiagnose autism?
HiBoop doesn't diagnose at all. It's a pre-screener. So it's our
Right.
psychiatrists and our like specialized clinicians that are able to support that interpretation, as well as with those clinical interviews. No pre-screener or psychometrics diagnosis on any level. That is where the human side of this. That's why it works as a like unconsensual marriage of the two together.
Does it over identify it in the population? Like, does it over screen for it?
I mean, I'm not 100% sure what you're asking, but it's based on their answers. So HiBoop's matrix is based on the scoring matrix that's done by a standardized psychometric test. So if they can somehow, quote, figure out how to answer the multitude of psychometric tests that we are doing as pre-screeners, and each of them kind of interplay, and then from there being able to come out with something that would go for any psychometric test. That's not a HiBoop thing. That's them figuring out a system that's completely different, respectfully. So what this is doing is it's giving data-driven psychometric tests that have been approved to be able to pre-screen, and then a psychiatrist or doctor are working off of that psychometric test to be able to have conversations to verify the test and make a diagnosis. These are just pre-screeners.
Yelena, you can.
Yeah, I mean, I appreciate we're running out of time, but just as someone who is a physician and does diagnosis, I think this is a really important part of perhaps maybe one of the myths of whether it's measurement-based care or HiBoop or anyone kind of using screening instruments, is that there is a difference between screening and diagnosis. And as I'm aware, all of the measures that HiBoop are using in the system are all screening measures and or kind of symptom tracking measures. And as this is what can be one of the challenges with implementation, is to have both the clinicians and anyone receiving or viewing or reading those reports, whether that's administration, whether that's a funder or a referrer or a patient or family member, really understand what the report, what those screening questions say and which do not, what they don't say. Because, I speak as an example, when I was working in a setting where we saw people with substance use disorder, coming in for in early recovery, who mostly, also had other concurrent disorders. When we did a screening questionnaire at the beginning of treatment, when they were just, kind of coming off of substances, lots of people, let's say, score high on measures of depression and anxiety, but that would require a follow-up then conversation and assessment, by me or my colleagues at the correct time in their treatment, and with a lot of more digging to determine, is that a true depression diagnosis or a true, let's say, generalized anxiety diagnosis, or are those symptoms representative of something else? And so I think there's a risk, of overdiagnosis if people are using screeners in a way, using them as a diagnostic kind of tool as opposed to as a screening tool. So that's part of, the education and the implementation.
Well, so great discussion. And to start, I want to thank Stacey, Jill, and Yelena for sharing your insights and experiences today. Really, really appreciate it. And, we look forward to continuing the journey with all of our partners and everyone here on the call. And you'll hear from us a follow-up. And also, thanks for staying over time. I think people are leaving now. But thank you, everyone. And really, really appreciate it. And thank you to everyone on our team as well.